so much, everybody. Thanks so much for joining. It's really a fantastic honor to be invited to speak on a topic that I feel very passionate about. So thank you so much for your attention. As Mario mentioned, I've been in Gallup here for over 10 years now, almost 11 years. And before that, I did my medical training at the University of California in San Francisco, where one of my primary care clinics was working in a transgender clinic. And that's why I really learned a lot more about providing primary care and hormone therapy for people who are transgender and gender diverse. And when I came out here some 11 years ago, a few of the doctors here said, you know, there actually isn't a transgender clinic on the Navajo reservation or in the area, and really encouraged me to start the program here. And we've probably been going now for about 10 years. It was very shortly after I arrived that we sort of started the clinic, essentially kind of put a separate half-day clinic here for me. And since then, we probably had over 130 patients in our clinic here. And I'm just super excited to be able to share. It's definitely, I as a general internal medicine doctor, I get to do a lot and see a lot. And one of the most rewarding clinical experiences really is working in the transgender clinic. And so that's the experience I bring with you here to this presentation. I know there's a lot of other experience here on the call. So please, I want this to be as informal as possible. Please jump in with any questions, jump in with any comments. All of your comments help to help me learn as well, as we know this, the terminology and everything are constantly evolving. And it's just so important for all of us to be patient and kind with each other as we're all continuing to learn and, try to take the best care of patients that we can. So let me go ahead and share my screen. All right, so what I wanted to talk about today, is that pulling up okay for you guys, the full screen? Okay, yes. Perfect, thank you. And so what I wanted to talk to you guys today about is the range of sex, gender expression, and sexuality. Understand the barriers to care for trans and gender diverse patients, the medical management for people with, quote, gender dysphoria, and I'll talk a little bit about that, it's a controversial term, and then explore ways to make our clinics more gender affirming. So first off, when we talk about what it means to be a man, what it means to be a woman, I think a lot of things come to mind. And one of the things that I think is important to say is that sex and gender, we often think of in this binary way a lot, but there are actually a lot of characteristics, right, that go into someone's sex and gender. And so although there is a specific term for male and female or man and woman, really, if you break it down into, what does it mean for someone to be a man or what does it mean for someone to be a woman, there's so many different characteristics, of which some of these four categories are just a few of them. One of them is your sex assigned at birth, which generally has to do with what the genitalia looks like, at birth. Particular sex hormones like estrogen and testosterone. So your primary sex characteristics, what genitalia we're born with, and then secondary sex characteristics, how hormones and things change at puberty. So that's generally the sex assigned at birth. Then there's gender identity, something that we can't necessarily see or measure or tell based on somebody else, but what our internal sense of gender identity is. And then there's gender expression, the way we express ourselves, whether that's in the way we dress, our posture, our roles in society, and then, sexual orientation, who we're attracted to. And in this binary sex gender model, and I'll just put up an example of how it's been extremely important for me to hear the feedback from, so many different groups. When I first gave this talk to a group of folks who are trans advocates in the Native communities, I had initially put up traditional sex gender model. And many of them were like, I'm sorry, which tradition are you referring to? Because that's not my tradition. And so I think really this more defines the binary sex gender model, which is that if you're assigned male at birth, that means you would identify as a man, you would express yourself in more masculine ways, whatever that means in your society in that place and time, and that you're attracted to women. And then the other part of the binary is female, identifying as a woman, expressing yourself more femininely and attracted to men. But would we be surprised to know that this binary system breaks down very quickly, even with something that we think of as so, perhaps that some of us think of as so binary as sex assigned at birth? And, we kind of think of it as, what makes up sex? And it's like these nice, neat boxes, right? With X, Y, and XX chromosomes, testicles and ovaries, testosterone and estrogen, the primary sex characteristics about what someone typically assigned male has at birth and what typically happens at puberty, and for females. But we know that there are a lot of people that don't fit into these nice, neat boxes, a term called intersex, right? Where people who may not even have XY or XX chromosomes, or even if they have XY or XX chromosomes, they actually have variations in the way that their body responds to testosterone or estrogen, or the way that their body, or they might have excess amounts of testosterone or estrogen that shapes differently their primary and secondary sex characteristics. So I think it's very important for us to realize that the only, one of the major things in terms of why when doctors and healthcare providers assign sex at birth is based on the genitalia. And yet we would think from that one characteristic that everything else would fall after into this binary category, it just starts to break down a little bit. So all in all, if you actually look at the people who don't fit into these boxes that are considered intersex, there's probably about estimating between 1 in 100 and 1 in 25 people. So about 2 to 4% of people who don't even fit into these nice, neat sex boxes. So if that's the case, we're starting to see that in the sex category, there is a lot of variation. And, there's no great model that can kind of incorporate the complexity of all of these characteristics. But this is one that I would venture, it fits a little bit more than just the binary model that we see, that there's actually a spectrum of sex assigned at birth. There's actually a spectrum of gender identity. There's a spectrum of gender expression, and there's a spectrum of sexual orientation. And why would it necessarily be that just because you are assigned a certain sex at birth, that would necessarily be inextricably linked to a gender identity? And so instead of having just those arrows pointing downward, you can start to see we're talking about arrows going everywhere, that there's no necessary reason why just because someone might arbitrarily have something that looks like a penis when they're born and thus assigned male at birth, that all of these things would necessarily fall into line. And so this is, I'll put in quotes, the revolutionary sex gender model, but I will also say for many of my colleagues and advocates who have taught me that many different communities, this is their traditional sex gender model. And so let me just pause a moment to talk about terminology. And so intersex, I talked about, it refers to a person who is born with a variation in whether it's chromosomes, gonads, which are testosterone, which are testicles or ovaries, or genitals that do not fit the binary male-female designations. And then there's transgender, generally an umbrella term for a person whose gender identity does not correspond with the sex assigned at birth. And there's gender variance, which is, it used to be called gender non-conforming, but I think that kind of puts a little judgment on what we should be conforming to, what is that norm. So it's just more gender variance, that behavior or gender expression that does not match the masculine or feminine gender norms. And then, homosexual, bisexual, anyone that basically doesn't fit in variations in sexual attraction, not just attracted to the opposite sex. And so, for example, you can see, so in terms of being transgender, the relationship between sex and gender identity, gender variance, the spectrum of gender expression in that third category, and then sexual orientation, the relationship between sex and assigned at birth, or the gender that you identify with and who you're attracted to. And then just another term, as I am someone who is cisgender, meaning that I was assigned female at birth and I identify as a woman, versus someone who is transgender. And I do want to say I can't see the chat, so if someone can help me, if anyone's chatting in, just feel free to read it out loud for us all. So unfortunately, many people in these categories are considered sexual and gender minorities, and many sexual and gender minorities people are discriminated against. But what we know by far, and so unfortunately, are that those people who are transgender are by far discriminated against the most. This was in the National Transgender Survey that was put on in 2015, and there's actually a new survey that had just come out in the last couple of years that the data is being analyzed. But what we see is that 30% report being fired or denied a promotion. 77% reported verbal, physical, sexual harassment in school. 58% experienced those same verbal, physical, sexual harassment by police. 40% report attempting suicide. And unfortunately, from 2011 to 2015, when the survey, when the last survey was taken, not a lot of these have improved. Maybe report being fired or denied a promotion has been improved a little bit with some equal employment opportunity laws, but significant increase in rates of harassment by police, for example, we're seeing, and the rates of people reported attempting suicide is still around 40%. And I think particularly relevant for the audience that we're talking about today, and me as in the healthcare field, is that 50% who saw a healthcare provider in the past year had a negative experience related to being transgender. Things are pretty worrisome for our transgender youth as well, where 93% of transgender and non-binary youth worry about transgender people being denied access to gender-affirming medical care. 60% of LGBTQ youth who wanted mental health care were not able to get it. So I want you guys to keep these statistics in mind about what is happening to a transgender person, the way society is treating are treating our brothers and sisters in the trans community. And keep that in mind as we kind of talk about how in the medical world we define someone who has gender dysphoria. So the DSM is means the Diagnostic and Statistic Manual of Mental Health Disorders, and it was updated in 2013 from the DSM-4 to the DSM-5 to incorporate the term gender dysphoria. It was previously called gender identity disorder. I think specifically the term disorder was removed to try to remove some of that stigma. But the fact that it is still in the DSM, the Diagnostic and Statistic Manual of Mental Health Disorders, shouldn't be a reason to stigmatize a group that has gender dysphoria on the one hand. And so it's controversial in that it even exists, and why does it have to be in the DSM-5? As a healthcare provider who, of course, has to deal with the realities of billing, has to deal with the realities of making sure that medications are available and lab tests, et cetera, are available, and that I can have a clinic for this, it's important to have a term, a billable term, that we can say that when I see my patients that I can, but that doesn't necessarily mean that it has to be in the DSM-5. Regardless, the term that I'm going to share with you here is what's listed in the DSM-5, gender dysphoria. And really the first three criteria essentially define somebody who is transgender, someone who has a strong and persistent desire to be treated as the other gender, manifested by symptoms such as the desire to be and be treated as the other sex, persistent discomfort with his or her sex or sense of inappropriateness in the gender role. And then it's really that fourth one as to why it's part of the DSM-5, that this disturbance causes clinically significant distress or impairment in social, occupational, and other important areas of functioning. For example, someone who drinks alcohol versus has an alcohol use disorder, someone who is feeling down versus someone who has a major depressive disorder. It's all about if it causes clinically significant distress or impairment in their function. And so that's generally the criteria that fits it into something like the DSM-5 would incorporate. And I guess what I will argue is that, as I mentioned, I am cisgender, I am not transgender. But if these things were happening to me, if I were being denied a promotion, if I were being harassed in school and by police, it would cause me clinically significant distress in my life, right? So it makes, again, you think about whether someone who is transgender, is it an issue with the individual person, or is it an issue with society's treatment of a minoritized group? So unfortunately, we do live in a day and age where many people who are transgender are discriminated against, it's been an incredible opportunity to learn here at the, working with the Navajo tribe about some Navajo traditional views on people who are transgender. And in the Navajo creation story, transgender people were really highly respected and revered because they could embody both male and female characteristics, could perform both male and female roles in society. And what my trans advocates have shared with me is that, it was only through colonialization and kind of people who came to colonize the area had more binary views of gender. And it was unfortunately at that point that the Navajo people started to repress more of their, more of these more broad views on gender. And so unfortunately, even among my patients who consider themselves traditional, still feel like they face a lot of discrimination, not just from dominant society, but from their, families as well. So barring a time where we could go back to Navajo creation story times where we were not treating our trans brothers and sisters the way that our society currently treats them, how can we help people who are transgender and struggling in the community? The one great piece of that, among other things that the LGBTQ Youth Mental Health Survey in 2022 found was that LGBTQ youth who feel support from family or attend a school or live in a community that is accepting of LGBTQ people reported significantly lower rates of attempting suicide. So I just want to throw out there, I feel like we often pathologize a lot of what happens, what is being done to the trans community. And I do want to say that many trans people live very happy, healthy lives. And sometimes it's because of, and sometimes it's in spite of the reactions of others and treatment by others. And so what I will say as a healthcare provider who, talks to other healthcare providers and the community who sometimes struggle with their own their own personal beliefs, we all have a right to our own religious and personal beliefs on sexual and gender minorities. We in the healthcare field also have an incredible opportunity to make such a positive impact and be that adult figure in their lives that can make them feel more accepted and decrease their rates of suicide and mental health and comorbid mental issues. We also have the incredible power to make a negative impact and perhaps isolate them from the whole healthcare community in general and make them feel like the healthcare is not accessible to them and not safe for them. So I think it's important for us as healthcare providers to make sure, as we signed on very early on, is to do no harm as much as we can. And for me, I've really been able to see the opportunity to make such a positive impact here in the community. So I mentioned a little bit more about this term two-spirit, which is documented in over 130 North American tribes in every region. Some of my patients who are Native American identify with the term two-spirit, the idea that you can embody both male and female characteristics. And I have some Native trans patients who say, I do not identify as two-spirit. I am not a man. I don't have any part of me as a man. I am a woman. And so just as with every single term that we've talked about, like I say, when I first came from San Francisco 12 years ago, a lot of these terms that I would have used back then are considered outdated. And so again, every term, just kind of use the term that the individual person uses to be the safest possible, instead of kind of putting words and putting labels and putting boxes on them just based on assumptions. All right. So what are some treatment options for people who have gender dysphoria? The first is mental health counseling, and I'm not a mental health counselor. So just from understanding, from talking to some of my colleagues who have more experience with counseling for those who have gender dysphoria, these are sort of the main categories, the main sort of approaches of talking to somebody who has gender dysphoria. The first is by far the most supported, the preferred way of counseling, which is affirming the idea that just to be open as possible to their individual exploration of their gender identity, and not necessarily have them feel like they need to be boxed into any sort of binary system at all, male, female, etc. As we go down, these are more harmful and even illegal as we go down this. So definitely affirming is the preferred method for mental health counseling. Then we have something called wait and see, which is the idea that you're kind of letting the child, these are often more referred to in children who are experiencing gender dysphoria, or who are just exploring all the different types of gender expression. And so wait and see is kind of allowing the child to explore both male and female, masculine, feminine, etc., ultimately expecting them to fit into some binary later on. Redirection, of course, there's positive redirection. Oh, don't play with this, play with this. Or negative redirection, don't play with this, slap your wrist. And then there's reparative or conversion therapy, which in many states, thankfully across the country, this is illegal. The idea that being transgender can be cured, and it's actually illegal in New Mexico, thankfully. And this is also something that has been not been supported at all by the American Psychiatric Association, by the American Academy of Pediatrics, the American Child and Adolescent Psychiatry Association. So thankfully, in many places, this is no longer considered legal. And so we then shift from mental health counseling to phenotypic intervention, so physical changes. And we always want to start with reversible things first, and then going towards partially reversible, and then finally irreversible. Especially for youth, we want to start with more reversible things. So social transitioning, like allowing the child to change their pronouns, their name, their haircut, their dress, whatever it is, and ensuring that it's comfortable. So if it may only be comfortable in the home and not necessarily in the school, etc. So making sure that it's a safe place for them to be able to explore their gender. And then starting around the age of Tanner stage 2 in terms of puberty, so the question is always, it's very, very normal to express all different types of gender expression and explore different gender identity as a child. When do we know if a child is going to have a transgender identity as an adult? And the idea is that, if it's consistent over, place and time, if it's persistent, and if it's insistent, not necessarily even just things like I want to wear this or that, but I want my penis cut off, or I am not their brother, I am their sister, continuing to insist on these types of, on these. And it, especially if it worsens at puberty, of course, because at puberty, you start to see a lot of the changes in the body that you're not identifying with, that they're not identifying with. And so that can cause significantly more distress. And so it's right around then that if we start to see more of this consistent, persistent, insistent gender identity that persists through puberty, is when we start to think about pubertal suppression as well, which is completely reversible, where it's something like it's a leuprolide or a GnRH agonist, which suppresses puberty essentially, so that it allows the child more time to continue to explore and see if that gender identity continues to solidify. And that can then, around the age of 14, 16 or so, can then shift towards partially reversible things like hormone therapy, which is essentially providing estrogen and testosterone. We know that at puberty, the shifts in hormones for those assigned male at birth tend to shift towards more testosterone. For those assigned female at birth tend to shift towards more estrogen. And so we just try to match those levels to make the changes that happen at puberty for someone who has a assigned sex different than how they identify. And we'll talk a little bit more about hormone therapy, which is really the majority of what I do. I should also mention that I'm an internal medicine doctor, so I only take care of adults over the age of 18. And so the predominant thing that I help with is hormone therapy. And then irreversible things really generally only allowed over the age of 18, and things that take away fertility only over the age of 21. And surgical interventions usually require a bit more, support from the primary care provider, mental health counselor to support a letter of support, as well as generally being on hormones or sort of having lived in that gender for at least a year. And so these are things that we'll talk about in a moment as well. And then finally, legal transition to the desired gender. And we are incredibly lucky in New Mexico to have, in Albuquerque, to have the Transgender Resource Center of New Mexico, which has compiled a lot of the paperwork that's needed in order for people to have their name or gender changed, information about on their driver's license, birth certificate, etc. And I work just off of the Navajo Reservation, right on the New Mexico, Arizona border here on the west side of the state. And so I also work a lot with Arizona, and it's just very interesting the differences between each state and what's required, what paperwork is required, what's required of me as your doctor to be able to say that your gender is a certain way. New Mexico does not require doctors to say that anymore. Arizona still requires me to commit to a specific language that says this patient is irrevocably committed to the gender change process, and I, under perjury of the law, agree to this. So every state is a little bit different. All right, so let me talk about hormone therapy. I think, as I put this slide up earlier on, that shares essentially that those assigned male at birth will have more testosterone, and thus causes a lot of the changes, the secondary sex characteristics that happen at puberty. So facial hair, body hair, deepening of the voice, increased muscle mass, etc. And then higher levels of estrogen, generally for those assigned female at birth, where you see breast development, wider hips, shift in distribution of body fat. And that's really what we're generally trying to do with hormone therapy, is essentially help the person have the changes in their body that reflect on the outside how they feel on the inside, for themselves and for society to treat them in the gender that they identify. I see a question there. Let's see. Okay, Lilin says, Transgender Resource Center has physical space in Albuquerque, but serves the entire state and can assist folks across New Mexico with legal documents changes and a slew of other needs. I totally agree. They're fantastic. And yes, as someone who lives on the west side of the state, I'm so incredibly thankful for them. And honestly, they've even been able to help some of my patients who live in Arizona too, to the best of their ability. So they really honestly are a regional resource for everybody. All right. So just to pause for a moment to talk about the efficacy of hormone therapy, I can probably find a more updated study that doesn't use the term gender identity disorder. So this is a study that was done back in 2010, which was a systematic review and meta-analysis of 28 studies with over 1,800 participants who were transgender. At that time, in the DSM-4, it was called GID. And so this was, their findings that 80% of individuals reported significant improvement in gender dysphoria when treated with hormone therapy. 78% reported significant improvement in psychological symptoms. 80% reported significant improvement in quality of life. 72% reported significant improvement in sexual function. I mentioned earlier, I am a primary care provider, as well as I work in the hospital, and it's so very rewarding to treat people who treat their pneumonia, get their A1Cs down for diabetes, hypertension, etc. And that's very rewarding. Even regardless of that, I never see this level of satisfaction with my blood pressure treatment, and so it's truly one of the most rewarding things. And I will just say that I feel incredibly honored and privileged to be able to have gotten training in Boston, San Francisco, and been able to bring it here to a community that is such in need and so appreciative of this care. And it's absolutely one of the things that has kept me going, working here for the last 11 years now, and hopefully many more years. So it's incredible to be able to provide this care and to be as helpful and supportive as possible for a group that is really truly so appreciative. So. All right, let me just go a little bit into, feminizing hormones. I will say, although I have a clinic here, I really feel like this is something that should be generalizable to all of primary care. You'll see the number of medications that we need to understand in terms of providing gender affirming care is a fraction of what we need to understand that's available out there for high blood pressure and diabetes. And these are things that we do on a day-to-day basis in our primary care clinics. And so this is absolutely is something that can be incorporated into everyone's primary care practice. So feminizing hormones and treatment, as was shared on the previous slide, essentially we want to see the effects of what happened at puberty for generally those assigned female at birth. The other thing I will say is that I kind of go through, you'll see I go through a whole consent form, which I'll talk about why I use a consent form, but which basically goes over, every single thing that they might expect to see, both reversible and irreversible changes. And it's very important for me to say, I wish we could pick and choose which of these things will happen when you start on hormone therapy, but it's important to know that all of these things may happen. And people on estrogen may have an increased risk of VTEs, venous thrombotic events, like pulmonary embolisms or deep vein thrombosis, DVTs. It can sometimes increase the risk, increase triglyceride levels. It can more unmask benign pituitary prolactinomas because estrogen does increase the risk, the levels of prolactin levels, can cause some emotional lability, hypertension, liver disease. There's always a question of whether it increases the risk of breast cancer, and data does not suggest that it increases the risk of breast cancer compared to other females assigned female at birth, but for the individual person who is assigned male at birth, starting on estrogen, it may increase their individual risk to that of generally those that were assigned female at birth and had more estrogen to start off with. So it doesn't increase beyond that of those on average assigned female at birth. So these are things that we monitor for, and I'll actually show you that there is an algorithm that I can send out to anybody that's interested about what things that you want to check for at 3 months, 6 months, a year, every year, etc., just for screening purposes. This is a great opportunity for me to talk about. We know that people who are transgenders face significant discrimination, and unfortunately also have a lot of comorbid mental illness, which sometimes means that they may seek alcohol, drugs, etc., as kind of a self-medication. And so this is a great opportunity for me to talk about if people who smoke tobacco might have an increased risk of DVTs, for example. So it's a great opportunity to talk about medications to help them cut back on smoking, get them the line for 1-800-QUIT-NOW to help with counseling for smoking. It also is a great opportunity to talk about liver health and making sure that we're talking about healthy amounts of drinking and the levels of risky drinking. And what I found, which has been incredible, is when people do start on hormone therapy, they are very motivated to make sure that it's as safe as possible for them so that they can continue and increase the dose that they need to get the effects that they're looking for. And people have been able to not only decrease their drinking, stop smoking, come off of their antidepressants when they feel actually more, when their gender dysphoria is treated. So it really is also an amazing opportunity to talk about all these things, as we should do in primary care always. That popped up there. Great. Okay, so forms of estrogen. I generally start off with the oral pill because it's a once-a-day pill that's easy to kind of titrate if people are having side effects early on. There can be a little bit of nausea early on, some mood stability, changes, things like that. So I generally start with the oral pill. The oral medication does involve first-pass metabolism, so it does go through the liver. So it may not be safe for people who, say, have a history of liver disease, severe liver disease, or history of blood clots, things like that. In that case, we do have other options. We have the transdermal patch, which I will say is by far the safest option for patients. It avoids first pass metabolism. So for anyone that does have liver disease, history of blood clots, things like that, it's absolutely the safest option. Unfortunately, it's also kind of the option that's can be the most annoying. The formulation that we have here, you have to kind of wear two, you have to change the patch twice a week. So every Monday and Thursday, say, which means that you have to keep the patch on for like 3 days at a time. And can you imagine showering, running, exercising, etc.? It's hard to keep it on, number one. And number two, sometimes it can cause a lot of dermatitis and reaction on the skin. So I try to, shift anyone who to relieve some of those, the dermatitis components, steroid cream, get them a Tegaderm to keep it on, to keep the patch on so that it doesn't fall off. And then finally, we have the estrogen injection as a possible option as well. This also avoids first pass metabolism. The challenge with estrogen injection, and I will say when I first started training, I had a lot more people on estrogen injection. Now I really, really reserve it because I found that the levels of hormone therapy are very, very erratic to the point where, so as you can imagine, just thinking about pharmacokinetics of medications, the pill, if you want kind of people generally to be at a level of those assigned female at birth, say between 50 and 150 estrogen, let's say you want to keep their levels around 100, the oral pill will kind of generally do that. The patch will definitely do that. The patch is the safest, levelest way to get transdermal patch. And then you have the injection, which is usually every 2 weeks, sometimes every week if you want, but that does this, right? And so it's these highs that can be dangerous. And then the lows that then sometimes can cause people to have some more mood swings and things. So I generally really don't like the estrogen injection because I've checked levels and sometimes it's over 1,500, over 2,000, which is just so high, and those high levels can increase the risk of some of the adverse effects that we talk about. So generally speaking, I try to do more of the oral patch and the transdermal patch. And then really, aside from estrogen, it's really just, it's really just spironolactone, which a lot of us are really familiar with just because for diuretic reasons, for hypertension reasons. And so it's probably just the only anti-androgen that you need to know about. Because just the risk profile compared to their benefit is just not worth it. So spironolactone. And we do go pretty high on the doses, 200, 300, even 400. You can split them BID, 200 BID. And generally speaking, I haven't had any issues with the, potassium, creatinine, but those are important to continue to follow as you're using this. So for feminizing medication, it's really just estrogen. And because testosterone can be so dominant, we give a testosterone blocker as well in the form of spironolactone. You'll see in terms of masculinizing effects, testosterone is very dominant. You don't have to worry about the estrogen that's in the body. Testosterone dominates. So really, it's just those three main medications that I use 95% of the time. Gender affirming surgical options. So for those assigned male at birth that identify as a woman or want more feminizing effects. So breast implants, vaginoplasty, creating a vagina, orchiectomy, removing the testicles. If you undergo an orchiectomy, it doesn't necessarily mean so sometimes people do this in stages. So people have the testicles removed. If their testicles are removed, then they don't need testosterone blockers anymore. And they can often come down lower on their estrogen levels. And so sometimes people opt to do that because it is definitely a more available procedure. For example, we offer it here at our hospital, but we don't have plastic surgeons that can do vaginoplasty. The important thing that I tell my general surgeon when he's doing the orchiectomy is to preserve all of that tissue, because should they want a vaginoplasty in the future, it doesn't preclude that at all, and there should be no issue with pursuing that in the future. And then there vocal cord surgery, honestly, a slew of other things, tracheal shaving, all of these various procedures to kind of facial feminization, etc. Unfortunately, in New Mexico, we don't have any of these types of specialists here. So there are people, of course, that, yeah, so. All right, and then we have masculinizing hormones, similarly effects of testosterone, generally what we see happening at puberty for those assigned male at birth that have their levels of testosterone increase. They can have increased risk of infertility, acne, shifting lipid profiles. So we always kind of check their lipids regularly. Similarly, opportunity to talk about alcohol use and the effects of making sure that we have a healthy liver to be able to process the hormones. 98% of people are on the intramuscular injection of testosterone. I will say among my patients, partially because the gel and the ointment is so expensive. That I do have a few people on the patch who are very, very needle phobic. But generally speaking, it's just the injections every 1 to 2 weeks. And all of these surgical options, removing the breast tissue, removing the uterus, removing the fallopian tubes, removing the ovaries. And so, we have OBGYNs here. They're general OBGYNs, and they do these procedures for other indications all the time. And so they, we do have people, of course, in the state that can do those types of procedures. And then but unfortunately, nobody that is doing metoidioplasties right now, which is essentially creating a penis using existing genital tissue, and then phalloplasty, which is construction of a penis from tissue from remote sites. Various new techniques that are coming about, but often one of the more common ones now, it seems, is using tissue from the forearm to create a penis. So the last few slides, let me just talk about in terms of things that I considered when I was kind of setting up our clinic here. Like I say, I think that it should generally be incorporated into people's primary care practice, just as anyone else who's just kind of coming in for care. Oh, great, we check for diabetes, we got you on hormone therapy, we check for sexually transmitted infections, you get your flu shot, just all as part of general primary care. Because I am a referral site for all of for the rest of Navajo area, as well as the larger area, I do have a separate clinic. And so it is like kind of set up like a half day. I have a specific nursing assistant who kind of helps with those patients, knows when they're doing callbacks, how to be sensitive to, calling people back and making sure that we're using the correct names. And then so some of those things. In terms of evidence-based hormone protocols, again, I'm happy to share this with anyone who's interested. As you can kind of see, there's one for testosterone and one for estrogen. It kind of goes through all the things that you should check depending on your age, how frequently you should check them, and then the general starting, mid, and max doses of testosterone on the bottom there. And so there's one for this as well as one for estrogen. And then I also have the consent forms. So I should mention, I work at a federal facility, and over the years, there has been changes in administration that trickle down to me, and sometimes the presence of my clinic is questioned. And so I think it's very, very important for me to have a consent form. And I call it, more for my patients, I call it an information form, to make sure that people know it's a 3-page form that goes through everything I know and everything I don't know about hormone therapy, how estrogen is going to affect their system, reversible, irreversible, when can they stop, et cetera, et cetera. So I use it more as an information form rather than consent. And if you don't sign it, but I can also say, whenever anyone has questioned my clinic, every single one of those 130 some patients on hormone therapy has a consent form scanned into their chart. And so it's important for me to be able to have that. It is by far and away not required at all. In fact, we prescribe medications for non-FDA approved indications all day, every hour. And so this is another example of that. But in those cases, we're not requiring people to sign a consent form. And so I do understand that it is partially separating, but I'm also trying to balance that with the unfortunate, political climate sometimes that we're working in. So I have these consent forms if you guys are interested in, and it's just honestly just great to just read through, especially if you're just starting to prescribe hormone therapy, as you're going through it with patients, so you're knowing some of the things to look out for and making sure you're not missing talking to patients about. Our electronic health system is not sophisticated at all. Many people are working on it, but this was one little thing. Unfortunately, we cannot actually change their name on there. So if your electronic health record is similar to this, there is a way. And sometimes I give this to the rest of the Indian Health Service who have a similar electronic health record. There's a way to put up a pop-up flag that says this person is transgender and their correct name is blank and their correct pronouns are blank. So, some of these workarounds that we've had to come through. And then augmenting services. It's over the years, it's been really incredible working with folks from our behavioral health department, from our speech therapy department, our surgical colleagues who over the years have reached out and said, hey, I would love to learn more about how to do speech therapy for people who are kind of working on their speech and pitch and frequency, et cetera. And so it's been great. There has been a lot of turnover over the years, so it's a constant kind of checking in on who might be interested in joining our team here, because you want to make sure that your team is vetted and that your patients feel comfortable seeking care. That's obviously very hard when just finding a mental health care provider, period, is so challenging these days. We have a transgender support group. I know the Transgender Resource Center has great support groups all throughout the day. They have a great calendar. These are ones that I would put out. This was before the pandemic, we've now shifted to Zoom. But before my clinic, I would just kind of order pizza and have people hang around in the waiting room, separate area together. So I'm hoping to restart that soon. And then I kind of referred to this earlier, but this is, for example, the request for sex change on your driver's license. And you can see previous ones a few years ago required a doctor to also also agreed to the gender. But now for New Mexico, you don't need to. You just need a notary to sign off that's you signing. Versus in Arizona, I was referring you to the language that I need to say for someone who what their gender is. And I declare under penalty of perjury under the laws of the United States that the foregoing is true and correct. So I have my template for that too. So, you kind of start to accumulate all of the various templates that you need that people start to ask about. All right, perhaps this is the most important slide of all. If anyone has been sleeping or has fallen asleep, I apologize. And this is the time to wake up. This is the most important thing in terms of a therapeutic alliance with our gender diverse patients. So I always introduce myself, and say, hi, I'm Dr. Wei. I use she, her pronouns. And what is your name and what pronouns do you like to use? And so just making sure that and of course, if they're introducing themselves, that's different than their dead name. And we've had to go over this with our front desk staff over and over again to make sure that we're using their preferred / correct name. I'm very curious to hear, actually, when I was training back at this point, 15 years ago now, we didn't really know how to ask about pronouns. We didn't really know how to ask about their gender identity, et cetera. We're definitely not taught as part of the standard part of history taking. So I'm curious if that's part of your standard history taking now for people that have trained in the more recent 15 years. And then, of course, the most important thing is I use the incorrect name or the incorrect pronouns. And the most important thing is to apologize and to be as sincere as possible, because people know our intentions. And so to just, again, put a sincere apology out, because, we will make mistakes. And I think it's important for our patients just to know that we are trying, and we apologize for using the wrong terms. Let me just click through these, offering gender neutral pronoun ways we can make our clinics more gender affirming, really prominently displaying all policies that prohibit discrimination based on sexual orientation and gender identity. Of course, training all your staff. It's not just people coming to my transgender clinic, right? They then go to the lab, they then go to X-ray, they then go to the ED. And so it's important for obviously the whole hospital to be aware. And we're actually training our staff tomorrow on this. So I'm really happy to be able to do that for our Pride Month too. And then, of course, trying to adjust intake forms as much as possible to include more than just male and female. Just a shout out to some collaborations that I've relied on over the years. Project Health is an online consultation that if you have a specific question, especially if you want to have more complicated patients who might have, say, a history of colon cancer or a history of a prolactinoma, or are on a lot of medications, some of which might interact with each other. The Project Health .org transline is really great for providers to kind of type in their more complicated hormone-related questions. I mentioned Transgender Resource Center of New Mexico already. The Northwest Portland Area Indian Health Board actually has a trans and gender affirming echo. I think it's every like fourth Monday or something, where you sign on and just like, I don't know if you guys know about the Project Echo model, but they do a little bit of a didactic in the first little bit, and then they have people present their patients, and you can kind of get feedback from the group about your patients. So the trans-friendly plastic surgeons in the area, unfortunately, the list is not too long, but these are some folks that definitely do gender-affirming plastic surgery. Toby Meltzer is probably the most comprehensive down in Scottsdale. He does every single thing that you can imagine, but it's very, very hard for him to get into. I'm not really sure what insurance is, if he takes insurance. And then Dr. Morehouse, I believe, he does more mastectomies and breast augmentations. I don't know if he's still active. That was as of like maybe about a year ago, but I'm unfortunately realizing a lot has changed with COVID. So let me stop there. And I think we still have a few minutes for questions. So let me stop sharing.
So we had one from Gabriela Morales. I'm trying to bring the chat up again.
Oh, great. I see it here. You described some of these, but what would be your advice for other health organizations that want to incorporate inclusive practices from bedside manners to documentation into their clinics, hospitals to support LGBTQIA communities seeking healthcare? Yeah, I mean, I think first and foremost, and believe it or not, we actually just finalized this policy like a couple years ago that, you know, is like when people who are transgender would get admitted to the hospital, we didn't know there was no policy of where to put them. I would truly get questions from my nursing staff being like, wait, is it illegal though for me to use the wrong name? And I'm like, what is the right name? What is the wrong name? I'm not sure what you're talking about. They're like, well, I have to use their legal name, right? And so there was just still a lot of confusion around that. So I think even just kind of looking into what the policies are in your organization, and if you'd like to see ours, I'm happy to share with you what ours are. And you know, we explicitly said for that you should use what, you know, the patient is presenting as. And the term preferred and the term correct has also been very confusing. I think we're trying to use the term correct name as like this is not like your preference. This is like their name. This is the correct name. But then we used correct. And then some of our staff were like, well, if you mean correct name, I'm supposed to use their legal name. And so it just got it can get very confusing. And so people do have good intentions and are just trying, but are just not sure what the right thing is to do. So I think it is important for leadership to be that example if hopefully leadership is supportive of creating a policy first and foremost, and then displaying that policy, not necessarily all 17 pages, but even just, you know, a brief thing that is put in all the clinic rooms to be like, okay, great. Actually they care about, you know, the fact and they recognize this. And so even seeing a sign like that, I think can be more reassuring for patients. I mentioned the turnover. I think over the 12 years or so, I've had, you know, like twice a year, there's a new staff that we kind of train. And so it can be exhausting in the emergency department, constantly new contractors, et cetera. So it does end up being exhausting, but I think at least having that policy has made a difference. Now we can say, oh, I understand why you're confused. Let me refer you to this policy. I would welcome anybody else who has had thoughts about how they've been able to make their clinics more gender affirming. University of New Mexico has a brand new gender affirming care echo as well. Ooh, that's great. Awesome. Do you want to, did you put it in the chat? Great. Wonderful. Thanks so much for that, Lylan. And then if an adolescent is on a GnRH agonist, do you stop the agonist when hormone therapy is initiated? Yes. Now, that being said, I'm an adult doctor, so I have not taken care of any youth or started anyone on Leuprolide or Lupron. But that's my understanding that you would stop that and then kind of shift towards hormone therapy. Or if they decide that they don't want to start on hormone therapy, it can kind of be stopped and then they will go through puberty as they otherwise would. Also, what is the goal range for testosterone levels in patients transitioning? Generally for those assigned male at birth, the hormone levels are generally around between 400 and 800. And so it really depends, as I was mentioning, where people can either inject testosterone every 1 or 2 weeks. It's still the same cumulative dose, but some people prefer, instead of having the every 2 weeks like this, to like kind of having it every week like this, right? The more frequent, the less the highs and the less the lows. So some people, especially who are on every 2 weeks, kind of find right before that next dose, before their next 2-week dose, they start to feel a little like tired, a little kind of down, drag. Sometimes if they feel that, I sometimes recommend trying to shift. So let's say they were on 100 every 2 weeks, we do 50 every week. And so it depends on at what point you check the levels. If you're checking the trough right before they're about to give their next injection, you generally want to make sure, that it might be on the lower end of that, 400 to 800, or even 300 or 400 or so is okay. If you've tested right after they inject, it's for sure going to be much higher than that, and that's okay too. So I would say a mid-range check between 400 and 800. The other thing I'll mention is for gender non-binary folks. Some folks don't actually want full masculinization to the level of those assigned male at birth, and so it's okay to shoot for something lower. Like they may only want a level of 100 or 200 instead of the 400 to 800, and that's totally okay as well.
All right, we're coming up on the end. Does anybody else have any questions they'd like to ask?
All I know is that MMC family medicine faculty has super fancy technology there. That is very impressive. Any movement, this camera is like totally watching you.
Yeah. All right. Well, if there are no other questions, we'll go ahead and close things out. Dr. Wei, thank you very much for joining us today.
Thank you so much. Yes, absolutely. Feel free to email me if you want any of those documents or have any other feedback. It was great to be here today.